we are going to discuss about a very, very interesting group of cases, which is a presentation of hypokalemia, which is quite common in pediatric practice, but often can have a lot of confusing areas in that regards. So we are all well aware that the most common causes of hypokalemia in pediatric practice are either gastroenteritis, in which this is usually associated with acidosis, or renal tubular acidosis in a more chronic sense, again associated with acidosis. Today, we are going to focus about a very specific niche of patients who have hypokalemic alkalosis and normal blood pressure. And as we discussed earlier in the last grand round couple of months ago, we talked about hypokalemic alkalosis with hypertension, in which we talked about aspirin mineralocorticoid excess, 11-hydroxylase deficiency, 17-hydroxylase deficiency. So today our focus would be individuals who come to us with hypokalemia, alkalosis, and have a normal blood pressure. 2-year-old boy with failure to thrive who presented with a weight of only 8 kgs, as we can see, and had a height which was compromised and had hypokalemia. Now, the most important approach in hypokalemia, of course, is to see whether there is a acidosis or alkalosis. So this individual had metabolic alkalosis. So this excludes a lower GI loss or a possibility of a RTA from that perspective. The next step, of course, was to look at the blood pressure, which was normal in this scenario. And then we looked at urinary calcium, which was found to be low. So in this scenario of hypokalemic alkalosis with a normal blood pressure and a normal urinary calcium, a possibility of Gentleman syndrome was considered. But when we are really reaching this scenario, we have to think of some other possibilities as well. And we found that he had hypomagnesemia. So again, going more in favor of a Gentleman syndrome. But very importantly in this scenario is that we have to exclude other causes, especially malnutrition, which will by far be the most common cause of this scenario. We found that there was a low fractional excretion of magnesium, suggesting that this was malnutrition. So it's very important that while we are evaluating, we should be clear about what we are dealing with and in which scenario the confusions and problems would be. So we have to look at all the possibilities, and we'll try to cover these cases today to highlight how to approach specifically in that regard. So a proper evaluation becomes very important. All of you can go and have a look at our website, which has got a lot of information as well as courses related to pediatric endocrinology. We have got multiple grand rounds along with postgraduate lecture series, which happens frequently, publications and mobile applications to make life easier in terms of pediatric endocrinology. So when we talk about potassium, it essentially is a balance between 3 sites in which the potassium is affected. We, of course, have the intracellular area, wherein the potassium is largely an intracellular ion. So it is within the cells and exchange with the plasma. Second, of course, is the intestine. So how much potassium we take. But remember the amount of potassium which is there in every food, because it's an intracellular ion, you will never become deficient unless somebody is on a totally parenteral nutrition. The most important regulator of serum potassium level is the excretion of potassium. And this whole axis is largely regulated by the renin, angiotensin, aldosterone system. So for anybody to have chronic hypokalemia, you need to have excess amount of the renin, angiotensin, aldosterone system. Like when you have chronic hyponatremia, your vasopressin has to be high. Similarly, for your potassium to be consistently low, you need to have more urinary excretion, and that is often linked with a high level of aldosterone or a high level of the renin, angiotensin, aldosterone axis. Now, we all know that there is a largely intracellular distribution of potassium. So the concentration of potassium is 40 times more within the cell, and 99% of our potassium is actually in the cell. So extracellular potassium may not be a good reflection of total body potassium. The classical example is in the setting of hypokalemic paralysis, where all your potassium goes into the cells, or diabetic ketoacidosis, where potassium has come out from the cells and your potassium is falsely high. Now, sodium is the opposite. There is a 14-time gradient between the sodium inside and outside the cell. And to maintain that, we have got a large energy-intense process of sodium-potassium ATPase, which really regulates this process. And a large amount of our energy is actually spent in this sodium-potassium pump. Now, this is triggered via insulin and beta agonists. So conditions in which you give more insulin or you give beta agonists, your potassium will become less. in that regard. There are two major other intracellular ions, magnesium and phosphorus, and as a rule, deficiency of one of them will cause deficiency of the other two. So if you have hypomagnesemia, you will have hypokalemia along with hypophosphatemia, along with metabolic alkalosis and hypocalcemia. So this is a very, very classical example of how single ion deficiency can have multiple products, and this is what we're going to discuss about also in one of our cases. As well as in the first case, if we saw, because of magnesium deficiency, you had all those problems which were happening. So hypokalemic alkalosis, hypophosphatemia, hypocalcemia, as well as a slightly lowish level of PTH will suggest a hypomagnesemia being an important possibility in that regards. Now, since kidneys are the major site of potassium homeostasis, we need to understand how kidneys handle potassium. Now, whatever potassium is filtered is all absorbed in the proximal tubule. The only potassium which appears in the urine has to be actively pushed out in the setting of the collecting duct. So basically, the work there is of the epithelial sodium chloride channel, which is basically regulated by the mineralocorticoid receptor. And this ENaC channel basically absorbs sodium along with chloride. The rapidity of movement of sodium is much more as compared to chloride. So there is an electronegative environment in the lumen, and this electronegative environment causes the pushing of potassium. So the potassium excretion is very, very closely linked to the amount of sodium which is delivered in the collecting duct. More the sodium, the body will conserve sodium more, and potassium will be lost in that process. Now, magnesium plays a very important role here. So if you have hypomagnesemia, you will be losing more potassium also from the tubules, and that becomes important. Another important positive ion which is lost is proton, which process is through ammonium production. So all those processes happen in that regards. When your potassium level is less, body would now like to say, okay, I don't want to lose potassium anymore. I want to push off protons. So your ammonium production will become more. So if you have hypokalemia, the natural response to hypokalemia is metabolic alkalosis. Remember, when your potassium becomes more, that potassium inhibits ammonium production. So acid excretion becomes less and you have acidosis. So hyperkalemia begets acidosis, hypokalemia begets alkalosis. So a normal, when you're talking about hypokalemia alkalosis, this is a normal physiological process. Hypokalemia with acidosis is against the tide. That is something you have to understand from that perspective. So now if you have any reason you've taken some diuretics like either thiazide or furosemide, or there is a tubulopathy in which you're losing a lot of sodium, it all will result in a scenario of more delivery of sodium in the collecting duct. So more sodium will be there for exchange, more potassium will be lost. So all these conditions, be it hypokalemic alkalosis, tubulopathy, loop or osmotic diuresis, they will all cause hypokalemia. And as I said, hypokalemia causes alkalosis. Alkalosis causes hypokalemia. So this is a vicious cycle which will keep on going in that regard. So this is something to remember. Now we know that the major regulator of the epithelial sodium chloride channel is aldosterone. The major role of aldosterone is to push the epithelial sodium chloride channel towards the membrane, and it increases the activity of the ENaC channel. So aldosterone is a major pathway which is in turn regulated by the renin system, which is triggered by a high potassium and a volume depletion, which produces renin, which converts it into ANG1, which is converted in the angiotensin receptor ACE enzyme into ANG2, which acts on the adrenals to cause production of aldosterone. So now we know that the renin-angiotensin system is a major regulator of potassium excretion. Now, from a pathophysiological perspective, hyperkalemia, as I said, a major component is 99% is within the cells. So there could be a cellular shift, which can happen with insulin, beta agonist, periodic paralysis, which are the major factors, or you have an extra-renal loss in which your urinary potassium is less, but you're using either via the vomiting or via the diarrhea. So you will have vomiting or NG aspiration, or you have cystic fibrosis in which you are losing through the skin from that regards. Now you can also have a urinary loss in which your urinary potassium will be high. And in this scenario, the problem could either be because of the RAS dependent pathway, which will basically be characterized by a hypertension in that regards. And this we already discussed. This could be a primary hyperaldosteronism, Liddle syndrome, apparent mineralocorticoid excess, CH variants 11, 17. This is not the focus of discussion today. What we are going to discuss more today from that regards is the RAS independent. Now here you can have secondary hyperaldosteronism, but this is not primary. Anybody who has hypovolemia will have secondary hyperaldosteronism, and that itself will trigger the whole hypokalemic alkalosis vicious cycle. So this could be part of tubulopathies. Now tubulopathies could be Bartter's or Gentleman syndrome, in which you are losing a lot of sodium as well as chloride, so that would be associated with alkalosis. It could be RTA, which again we are not going to discuss today, which would be acidosis. And finally, you can also have osmotic diuresis or a diuresis also. So diuresis, we said you have more sodium delivery, you will have hypokalemia and alkalosis. So predominantly, I would say three major causes, what we're discussing today, would be the tubulopathies like Bartter, Gentleman. Close differential to them will be diuretic. So Bartter's is like furosemide excess, and Gentleman is like thiazide excess. This is what you can think of simplistically. Then magnesium deficiency per se, what it can do and how malnutrition can affect will be the other scenario. And of course, diuretic use, as I said, will be a close differential. So we'll be focusing largely about RAS independent urinary loss is what we are looking out in that perspective. Now, I've already mentioned that alkalosis is a major trigger of potassium excretion. We discussed that hypokalemia increases ammonium production, causing proton loss, causing alkalosis. That was one arm. But alkalosis itself will cause hypokalemia. So when you have alkalosis, basically your bicarb becomes more. So your body will push proton from the cells and potassium will go in. So you will have hypokalemia, and this proton will also, bicarb will also be exchanged there in the kidney. So you will lose both in the cell and in the kidney. So therefore, if you have alkalosis, it will be getting hypokalemia, a vicious cycle, as we have discussed, will happen. We discussed earlier that for every 0.1 decrease in pH, the potassium increases by 0.6. That is the response for metabolic acidosis. For alkalosis, it is slightly lower. It is like 0.4. 0.4 millimole decrease for every 0.1 rise in pH is what we need to remember. And this is true for both respiratory as well as metabolic alkalosis. Now, from that perspective, now we'll just touch base about how do we classify hypokalemia. The most important here is, of course, to look at the pH. Now, everybody with hypokalemia should have alkalosis except three conditions: renal tubular acidosis, acetazolamide use, or lower gastrointestinal loss. So alkalosis is not really going to tell you much in that regards. The next step, of course, is to look at volume or blood pressure. So in this scenario, if you are hypovolemic, this is what we're going to discuss today. If you are hypovolemic, you're dealing with losing a lot of sodium, losing a lot of acid. That is why you are having alkalosis. So diuretic, malnutrition, Bartter, and Gentleman. These will be the four things which we'll focus today, in which you will have high urinary chloride. You will be losing, that's why you are hypovolemic. Your magnesium may also be low in most of these scenarios. So BP will also be low and normal. So this is the classical scenario we are discussing. If on the other hand, you have a RAS axis, you will have high volume, you will have hypertension, and that's what you will pick up from that perspective. And finally, RTA and diarrhea will have metabolic acidosis. So we're dealing with hypokalemic alkalosis with normo/hypovolemia. So this is what we're talking today. Now, if we go by our approach, we all know that blood gas is a central part to evaluate in the setting of hypokalemia. But before that, you exclude diarrhea, diuretic use, and malnutrition. If there is acidosis, you go more towards the possibility of RTA versus GI loss. You look at urinary anion gap, If you are dealing with alkalosis and your blood pressure is low or normal, you're dealing with malnutrition, Gentleman syndrome, Bartter syndrome. These are the sort of differential, and of course, diuretic use. So that you have to be aware of in that scenario. And this is what we're going to look at. Now, before we start off with the cases, I'll touch base a bit about what we are really looking at in that regards. So from a very simplistic perspective, we can consider that Bartter syndrome is a defect in the sodium-potassium 2-chloride channel, and this is a channel at which furosemide or the loop diuretic acts. Now, because of this, you will have more delivery of sodium in the distal tubule. The delivery of sodium will say, okay, body will say, we are losing a very important thing like sodium, let's exchange. So it's going to ready to sacrifice potassium, proton, calcium, magnesium in exchange to this sodium. And because of this hypovolemia, your RAS axis also goes up. So your ENaC channel goes up, it starts overdrive. You're losing proton, you're losing chloride, you're losing potassium. So you will have hypokalemic metabolic alkalosis with hypokalemia. So this is what will happen. There will also be an induced AVP resistance because of hypokalemia also, which will cause polyuria and DI-like picture, which will happen. And you will also lose calcium and magnesium. The calcium loss will cause hypercalciuria and nephrocalcinosis. So the most severe form will actually present even before birth with polyamnios, and subsequently there will be a lot of failure to thrive. So this is the classical presentation as far as Bartter syndrome is concerned. And if you look at somebody who's taken furosemide for a long time, like if you talk about a preterm baby who has a hyaline membrane disease, who has got cardiac issues, you're giving furosemide, you do develop nephrocalcinosis, you do develop failure to thrive. So this is exactly a replica of furosemide toxicity. So this is the experimental evidence of nature of how furosemide excess will do on a long term and can be quite detrimental. So you will have hypercalciuria, hypermagnesiuria, you will have hypocalcemia, hypomagnesemia. So everything is low. Calcium, magnesium, phosphorus, potassium, pH, everything is going on that direction in that regards. Now, just to keep it a more nuanced look, because we'll be talking about a specific form of Bartter syndrome today, so we'll dig a bit deeper about how this tubular area works in terms of absorption. So essentially, you've got the sodium-potassium 2-chloride channel, which takes, so this is like carrying sodium chloride and potassium from the lumen to the tubular cell. And from there, you have got the sodium-potassium ATPase, which allows exchange of potassium. So this essentially means you are absorbing sodium while you are exchanging with the potassium from that regards. Now, this potassium is thus pushed out via the ROMC process into the lumen in that regards. And this chloride is then pushed off also via specific chloride channels, ClCkA and ClCkB. So the net effect of sodium-potassium 2-CC, sodium-potassium ATPase, chloride channel and ROMC is that you're taking in salt, sodium chloride, and you're losing potassium. This is what you are exchanging between circulation and the lumen. You're taking in salt and you're losing potassium. This is what basically this whole pathway is doing from that regards, and this creates an electrical gradient. Now, because of this electrical gradient, there will be absorption of calcium and magnesium. They will be taken in through the paracellular pathway because of this gradient from that perspective, and you are absorbing that. So this is a normal scenario. So now in situations wherein you have got more amount of calcium, or if the whole process is affected, so if your calcium sensing receptor becomes hyperactive, a specific compound like HETE, which is a prostaglandin derivative, will start to disrupt the ROMC pathway, and this will result in disruption of the sodium-potassium ATPase, and this ultimately will result in a scenario where all the gradient is lost, and you will be losing potassium, you will be losing calcium, you will be losing magnesium, and the whole process becomes abnormal. So you now have multiple places where you will have manifestations like Bartter syndrome, or you can say phenocopies or variants of Bartter syndrome. So the most severe form is the sodium-potassium 2-CC, which is the type 1. severe form. The ROMC defect will also have a severe form, which will basically have a problem in terms of electrical gradient, and you will be losing again from that perspective. We know that there are abnormalities in the CLCKB and CLCK1, which have type 3 and type 4 RTA. We'll be specifically talking about one of those defects today. And of course, if you have calcium sensing receptor mutation, which is activating, it will cause hypocalcemia, hypercalciuria, and the whole, this is the mechanism how it is causing. So again, that's the type 5 Bartter. So essentially, Bartter syndrome is not a single disorder. There are multiple genes which may be affected. Common to them is the loss of potassium, loss of chloride, calcium, and magnesium. So hypokalemic alkalosis, hypercalciuria, hypermagnesiuria is a basic factor which will be there in that regard. So if you just compare, type 1 is the sodium potassium 2 chloride, most severe form, and you have an antenatal form. The type 2 also is very severe in that regard. This is the potassium. So effectively, if the potassium doesn't go, or sodium potassium, your whole pathway is disrupted. So you will not be losing in that regards. Type 3 and type 4 are milder forms, and they may cause hypercalciuria and deafness. And finally, type 5 with a calcium sensing receptor, and we know it more in terms of hypercalciuric hypocalcemia, the form of hypoparathyroidism that we have discussed earlier. What about Gentleman syndrome? So Gentleman syndrome basically is a defect of the thiazide area where thiazide acts as the sodium chloride symporter, in which you're losing sodium, and because of this loss of sodium, it will be reabsorbed, and you will then be having an exchange which will happen, and you will be losing again potassium, chloride, and proton. You will have hypokalemia, hypochloremia, metabolic alkalosis, and very importantly, magnesium loss becomes much more. Importantly, here the mechanism does not cause hypercalciuria. It's a hypocalciuric variant. So in a child who has hypokalemic alkalosis, you have to look at the magnesium level and the calcium excretion. You will know whether it's more likely to be Bartter versus Gentleman. So low magnesium, high urinary magnesium there. So to compare between Bartter and Gentleman, Bartter is a much more severe problem, especially the severe defects. Both of them will have hypokalemic alkalosis. Bartters may present even in the newborn period, as discussed. Blood pressure is usually normal in Gentleman because the loss, it's not that severe defect, so to speak. Serum calcium tends to be low in Bartters, while urinary calcium is high in that regards, and magnesium tends to be lower more in Gentleman. So Bartters will present very early, failure to thrive, polyuria, hypokalemia. Gentlemen will present later on with cramps, with muscle pain, adolescent. That is the usual presentation which will be there from that regards. And of course, polyuria will be there. So now, if we focus specifically on our scenario of alkalosis with normal blood pressure, the first thing is to exclude simple things like vomiting, NG aspiration, and diuretics. Then your urinary calcium, magnesium, and urinary magnesium will give you the trick. In Bartter syndrome, you will have hypercalciuria. In Gentleman syndrome, your magnesium excretion will be more. But if it is a primary hypomagnesemia, your magnesium excretion will be less.
So we have this 10-year-old boy who was born of non-consanguineous marriage, and he came to us with a complaint of growth failure, which started with the age of 4 months of age, and he had a complaint of recurrent fever. Let's start from the beginning. He was born full term with a birth weight of 3.3 kg, and he was delivered by a cesarean section. His antenatal mother gave the history that there was no history of any polyhydramnios during the antenatal period. And the mother stated that at the age of 6 months, she noticed that he was not gaining weight despite of having adequate milk intake, which was a mixture of breastfeed and the cow milk. And he had a multiple episode of unexplained fever, for which she has to take him for multiple doctors, and even he was given ATT treatment also, but no one found out the diagnosis of the fever. he was not gaining weight at the expected rate for his age, and he became easily tired even after playing for a shorter duration. But there was no history of any. He had a persistent generalized weakness and lethargy throughout the childhood. But he was able to wear clothes, comb his hairs, and wear his slippers. There was no history of any localized muscle weakness.
Just hold on. You have a child who has basically failure to thrive. Along with that, you've given a history that there are multiple episodes of
Unexplained fever.
So
Right,
in
sir.
a boy who has got failure to thrive and recurrent episodes of unexplained fever, what would you think of? From an endocrine perspective, because we are talking in endocrine.
So, so this points towards an etiology of dehydration happening here. So we will need to consider something like an early onset DI or a
So recurrent dehydration.
Yes, sir.
X-ray scenario.
Yeah, definitely.
Adrenal insufficiency will cause much more sickness.
Sickness,
So the
right.
patient will become into crisis. So this is like that disease which is not that severe, but it is causing dehydration. But the patient is not able to grow, but he is not going to die immediately.
Also.
That's what sort of scenario is saying. So yes, nephrogenic DI would be something which I'm going to think about in that regard. Now your history is also very important. Is generalized muscle weakness and lethargy. So if you so you haven't asked about polyuria.
Yeah, I have asked, sir.
So yeah, so polyuria would be something.
There was no history of polyuria or polydipsia or nocturia.
So
he hadn't any
because
history
in
of
the
it.
early age group, definitely they don't have access to water.
Yeah.
So if they can't have water, they will become dehydrated. And that is why they have got this recurrent fever.
Yeah.
Now, if you club this fever with muscle weakness, dehydration with myopathy, what do you think, Vima?
Dehydration with the myopathy, like muscle weakness, not exactly myopathy.
Yes,
it could be due to.
So can the DI cause that picture typically?
So it could be due to recurrent malnutrition. It could be the cause.
So you can think of hypokalemia.
Hypokalemia due to any malnutrition, like a celiac, could be the cause, and it could be due to any malabsorption, like GI symptoms. Like he was having a unexplained fever, like a recurrent GI infections. He was having recurrent.
You can think of that sort of scenario, right? So this is a non-specific finding. But the big message is that if you have anybody who has failure to thrive, even without fever, if you have fever or dehydration, do a electrolyte. I think that's the basic thing. So that if there is a DI, you will get hypernatremia. If there is these sort of disorder, you will get potassium. That is the big message.
Yes, sir. As his mother gave he hadn't have any history of polyuria, polydipsia, or nocturia. And he has no history, he had no history of recurrent vomiting, any bone pain, or any bony deformities. He had never had recurrent abdominal pain, loose motions, or any preference to rise. He has no difficulty in hearing as well.
Why are you asking for hearing?
So because as I was suspecting, like in some cases of like if you are suspecting of a tibulopathy, there is a chances of having this hearing defects in the.
Okay, so you are thinking beyond.
In the DI also that there is a history of her.
Okay. Now recurrent, you talked about the bone pain.
So because for the patient is having this failure to thrive or bone pain, RTA could be the possibility of RTA.
Although they distal may have dehydration, but they are not that dehydrated. They usually come with atherosclerotic breathing and other parameters more.
No history of similar complaints in the family, just to rule out if any DI in the maternal side of the just. He has no history of recurrent respiratory infections or the steatorrhea, just to rule out the cystic fibrosis. And no history of any increased pigmentation, just to rule out the any CH or any sort of wasting crisis.
Could this be pseudo-hypoaldosteronism? So CH or other thing, you will have pigmentation.
Pigmentation,
Features. Can it be PHA?
could have.
So how would PHA present?
Say, the patient presented with failure to thrive and
The recurrent
infections, same presentation.
Everywhere electrolyte becomes
Very important.
So that will be the other.
Yes, sir. And in the past history, like he had multiple admissions for fever, and he also received ATT. Just he was not just for multiple episodes.
There is a saying that if somebody has received ATT, it means that he has some illness.
Yeah.
So he has gone to the doctor many times. They have given him
ATT because he was not gaining weight. He had fever. So
ATT may be a marker of chronic illness.
Chronic illness. Yes.
He was sick enough for people to think, okay, let's let him give it.
Yeah. There was no significant antenatal and postnatal history, and his development was absolutely normal according to his age. On the examination, this pulse rate was regular, normal volumic, respiratory was normal. Even the blood pressure was 90/60, which was normal tensive for his age. Random blood sugar was 89. This was normal glycemic. And on the general examination, we found there was no pallor, clubbing, or cyanosis or edema. He had no syndromic facies, and there was no bony deformities, and he has no organomegaly. When we examined the child, we found that both his height and weight were affected equally, and his weight were more affected.
This was when he had come for the
First time at the 12 years of age. Yeah.
And he had problems for a long
time.
So
Right.
it tells you how this problem was missed for such a long time. And then he lost a follow-up.
Yes, sir. His weight were more affected than the height. So definitely it is a nutritional pattern of growth failure. And he was prepubertal at that time. And so on the differentials on the basis of failure to thrive and the muscle weakness, my first differential would be malnutrition, celiac.
Celiac, you think is likely because given the very early onset?
Yes, sir. At the age of 10 years, 12 years.
You said that he had
4 months, sir.
4 months. So celiac becomes unlikely.
Less likely,
so
or
it is very, very early.
Yeah.
So you have to say something which is because celiac you need to take wheat.
Oh, year, yeah, at least.
So at least 2 years, generally 1.5 2 years. So it is very, very unlikely. All the infections become unlikely because you have taken very nice history that there is a very early onset.
Yeah.
So which basically you have to think of, okay, whether he is using from the gut or he is using from the kidney. That will be your basic thing. There is some problem in either absorption or some problem in the renal absorption, whatever you can do.
Tuberculosis.
Less likely.
Tuberculosis could be the possibility as he was not
He will not survive for 14 years if somebody is tuberculosis.
Yeah, it could be the
So
possibility.
it's too long a history. So these are all possibilities.
Possibilities, just a possibility.
Then when you think of it, it is not likely that somebody will have tuberculosis for 14 years.
Congenital heart disease could be the, as he was getting easily tired very easily after
his survive.
A cyanotic mild form of
so he will not have that failure. So you have to think basically. So you have taken a very good history, but then you have to think of what is likely. So somebody with a severe CHD, which is called CCF, at 12 years would have problems. So I think your history basically means that you're looking at either a tubulopathy or you are looking at a possibility of a GI problem because diarrhea is not fine. So that becomes more likely. I'll take it up there.
Okay. RTA, Bartter or Gentleman, and the diabetes insipidus or any use of diuretics could be the concern.
Diabetes insipidus till this age would definitely have developed a polyuria.
Yeah.
Because it's only in that first year of life when they don't have fluid access, they will not develop polyuria. Otherwise, it's very unlikely they would definitely have polyuria by this time. So again, all these are possibilities, but
in order, better way. So when we did the examination, we found out that the serum sodium was low. It was 122. The serum potassium was also low. It was just 2. Magnesium was in the normal in the lower side of the normal range was 1.8. There was metabolic alkalosis. pH was 7.5. And there was a excretion of sodium and potassium in the urine. It was more than the expected range, that is 97.3 of the sodium and 57.
Just hold on. Yeah. So now you've got you can make the diagnosis with this investigation itself. So Alapan, you have got low sodium, low potassium. possibilities of hyponatremia, hypokalemia causes. So everywhere we say hyponatremia, hyperkalemia. Hyponatremia, hypokalemia. So hyponatremia, hypokalemia means what? Basically, it means that you are losing it either from the gut or from the urine. So in this scenario, so there is two possibilities. Now, which investigation tells you that you are losing here from the kidney and not the intestine? It's the urinary
potassium.
So I said that urinary potassium should be high if it is a renal loss. It's high. So this now very clearly tells you that you are losing something from the urine. Kidney. Now, how do you know that this is not RTA? Because there is alkalosis. So if you just look at these investigations, you make the diagnosis. So this very clearly tells you in a child who has very early onset failure to thrive, who is not growing well, and in this scenario you have hyponatremia, hypokalemia, metabolic alkalosis, you are thinking clearly in the setting of a tubulopathy. And within tubulopathy, what are you looking at, Dhani? Bartter versus gentleman, what is more likely?
In the set. It is a mixed picture right now, but in the setting of normal magnesium levels, it goes to the further, but we also have
hypocalcemia.
Sodium, you will not get in gentleman.
Yeah, definitely.
122 is huge, potassium is 2. Gentleman is more like a milder disease, cramp, something like that. This 122 sodium is very, very. So this is earlier, this is classical, this is Bartter written over it. So what I'm trying to say is that you don't need to be apologetic to say Bartter is a possibility because he has 4-month onset of recurrent dehydration and he was not growing well. And so in that scenario, things are limited. Now you get the diagnosis, so you don't need to think of celiac.
Definitely.
Make sense in this. So this was classically, you will do celiac to rule it out, but you're not thinking of celiac. Now, metabolic alkalosis is 7.5 with base excess is plus. So this is classically a typical case of hypochloremia, hypokalemia, and metabolic alkalosis. Now your calcium level is normal. Maybe normal. Magnesium is normal. There is no hypercalciuria.
And
there are few things which are there, and ultrasound.
So no calcinosis.
So, but still, I will keep Bartter as a
strong possibility. Definitely, sir. Now, if I summarize the case, we have this 12-year-old boy who had failure to thrive since 4 months of age, and he presented with muscle weakness too, and his blood pressure was normal. And in the lab investigation, we found out there was a metabolic alkalosis with the hyponatremia and hypokalemia, and with normal magnesium and hypocalcemia. So, as sir has already mentioned, the Bartter syndrome has to be the first possibility. But as there is a hypocalciuria, so Jitterbell syndrome could be the possibility. So the points more in the favor of Bartter syndrome, the age of presentation, as it is the early presentation, normal magnesium, and points in the favor of Jitterbell syndrome, the mild severity, as it is.
It's not mild. 120 sodium, you cannot say mild.
Sir, but he doesn't have polyuria, and he was just a muscle.
Mild, but when you say Jitterbell is much milder.
Okay.
So 120 sodium can never be mild. He is tolerating.
He never presented with polyuria, and he just
He somehow he managed.
Okay.
But 120 sodium, you can imagine, is too low.
Okay.
That's potassium.
Okay.
So this is not that mild.
Okay.
So within Bartter, it is mild.
Okay, sir.
So, but it is not that mild as compared to the Jitterbell syndrome, when you can say in that regards.
Okay, sir. And he had normal calcium and he had hypocalciuria too. And there was a muscle weakness only, no polyuria. So we get the genetic testing done, and what we have found that he had a genetic mutation in the chloride channel, which was a homozygous mutation in the chloride channel, and it was a Bartter syndrome type 3, which was autosomal recessive. And
so do you think this is likely pathogenic?
Pathogenic? Yes, definitely,
because
sir.
everything is fitting into a picture.
Yes, sir.
Now, if you go into our discussion that we discussed, that ClCKB is the one which pushes the chloride out.
Yes, sir.
So most important is sodium to go in and potassium to go out. That is sodium, potassium,
chloride,
and ROM. So they will be the most severe. That is the first step.
They will present
now,
very early.
Everything can happen, but chloride is not going out. Which means after some time, this exchange of chloride will not happen. Something like GHD. You say, okay, GHD1, you don't have glucose 6-phosphate.
Okay.
So you will have no glucose. Then you go to the next level, you say, okay, till the branch, I will get that, after that I will not get. Then you have got GHD 6 and 9 will be the same here. So if you have got no sodium potassium 2 cc, wrong, most severe. CLCK will be less severe. But within that severity, they will be much more severe than that of Bartter syndrome.
Right.
Then the gentleman syndrome. You need to understand that Bartter is very tall.
Early.
If you have a short Bartter, he will still be very tall.
Taller than gentleman.
The severity of milder Bartter will be much more than the severe gentleman.
Okay. So now coming to the management, see how we have managed this child. We increase the calorie intake of the patient. And as the salt supplementation was not required, as he was preferring a high.
This point you mentioned, and this is important.
Yes, sir.
Like to have sauce.
Yes, sir.
They will like to have more.
And for the hypokalemia, we prescribe the podclor with a dose of 2 milliequivalent per kg per day, and we aim to keep the serum potassium greater than 3 millimole per liter. And we started the tab endomethacin with a dose of 1 to 2 milligram per kg per day. But it has to be keep in mind, when we start the endomethacin dose, if we give it with a higher dose, like 2 milligram per kg per day, he is more prone to have like headache or gastritis. So we have to start the tablet with a lower dose. Like
how does the endomethacin work?
So it decreases the prostaglandin, and it's so prostaglandin, if the prostaglandin decrease, it will decrease the renin, and it will maintain the potassium.
Local mechanism.
Yes.
Like you were discussing in that aldosterone effect also, that the local prostaglandin will be inhibited by that.
Yes, sir. So we have to keep in mind the side effects of the endomethacin, like the headache. It is a dose dependent. So we have to slowly titrate the dose of the endomethacin. Gastritis, so we have to give this Pantop coverage along with it. And the main thing is, during the illness, fever may be masked by it. So we have to keep eyes and ear open during the illness and see the signs and symptoms of illness. And the follow-up should be done every 3 monthly, and we should do venous blood gas, sodium, potassium, urine, calcium, create, and magnesium. Now this International Kidney Organization have given us some guidelines, and they have clearly mentioned the type 3 Bartters, and our case clearly fits on these parameters of type 3, like the age of onset of the type 3 Bartters is 0 to 5 years, and our case clearly presented in the 4th months of age, and the polyhydramnios is absent, as it is present in all the other types of the Bartters, and the failure to thrive and the nephrocalcinosis is definitely absent in type 3, and it was absent in our case too. And there is a mild hypomagnesemia, and there is a variable nephrocalcinosis, as it was absent in our case too.
So I think now if you look at our case, it is fitting
exactly into the type 3.
Because type 5 will be that hypocalcemia, hypoparathyroidism. 1 and 2 are very severe. They will be extremely, we have seen patients and very difficult. They will not survive till this day. Let's put it this way. They will die within a year if you don't manage them. So type 3 is what we are looking at, and there is no definite on that regard. So this is, I think, good for the patient also.
Yes, sir.
It doesn't have other associations.
They have also given the guidelines regarding the follow-up cases, follow-up visits. So we should also look for the dehydration, degree of polyuria, signs of muscle weakness, growth in the psychomotor development during each visit, and do the biochemical workup like acid-base status, magnesium renal function status, PTH and urinary calcium excretion, and do the renal ultrasound at least every 12 to 24 months to monitor the nephrocalcinosis. And one thing I would like to emphasize here, that it has been seen that the growth hormone deficiency has been reported in many cases of the Bartter syndrome, but we should not jump into the growth hormone therapy in the cases of Bartter syndrome. We should first control we should give the high calorie intake in the patient. We should correct the electrolyte first, and even if the patient is not growing well, then we should consider the recombinant growth hormone therapy.
I think that is because assay when you're doing when it is not controlled, you will label them as GHD.
Yes.
So you have to be very cautious in doing this.
Yes, sir.
You can't have two pathologies, is not very common. The Bartter is, what is the prevalence that they have mentioned?
So they are very rare, but very rare.
So 1 in a million into 1 in 1500, so this becomes very, very rare. So before you say, okay, these two are coexisting, think that this could be because of the
errors. Because we have seen in our case, once we have started the treatment, he has gained a very good height. Even after he has lost to follow up, he had poor compliance. He had gained from 126 centimeter to 154 centimeter, and he had gained good weight. So the main message from here to consider the Bartter in gentlemen in the cases where there is a failure to write. 1 year of age. And he could have gained much height if had come more regularly.
The first case, which was actually a very early onset of problems, which was missed out and which was picked up later on. So that was a scenario where the vigilance was required at the initial stage. The second case also gives a big message that if you have somebody who is not eating well, who is not doing well, especially conditions like diabetes, celiac disease, Bartter's, Down syndrome and other scenarios, think of all these nutritional deficiencies. They are very, very important, and they can even cause respiratory paralysis, as happened in this case. And third case is, yes, we need to be vigilant, think about the scenarios, but don't be over cautious in terms of making a diagnosis. So before you make a lifelong diagnosis, you have to be careful in not jumping onto that. So I think third case most likely will be a nutritional scenario. So this is how we discussed about the various aspects of hypokalemic alkalosis. So in anybody who has hypokalemia, look for blood gas. If there is alkalosis, look for blood pressure. If blood pressure is normal, think of a tubulopathy, think of malnutrition, think of diuretic use, and then you start thinking of Bartter's in gentlemen from that regard. So we'll see if there are particular questions. Duration of indomethacin. So in Bartter's, you would need for long time. Of course, with age, the requirements may go down, but usually it's lifelong. There's also a treatment option with amiloride, which can also act, which is basically a potassium sparing. So if you think very simply that you have hypokalemic alkalosis, so you will use a drug which causes hyperkalemic acidosis. That classical drug would be your amiloride. So how will amiloride basically act? Your sodium is being delivered, but that sodium has to go in using the epithelial sodium chloride channel. Now, if you block that channel, you will of course have an issue from there. So then sodium will be lost, but your potassium will not be lost. So your hyperkalemia will be conserved on that. So it is a common. So it is also a treatment along with that. So if you have not predominant hyponatremia, but more of hypokalemia, then that is drug which is added on along with indomethacin.